a sort of autoimmune picture, which then thus includes an Addison's diagnosis. So could you go into the next slide, please? Great. So investigation. So using these are so important for an Addisonian picture, and I'll quickly talk through them. So the way I like to think about these electrolytes is that it all kind of revolves around aldosterone for me. So aldosterone is a hormone produced by the adrenal cortex. And now what aldosterone does is it takes up sodium and as a byproduct pushes out potassium, and with that hydrogen plus H plus ions, essentially acid. And because it pulls up the sodium, it increases blood pressure because water comes in with it. So in an Addisonian picture, you're not going to have this aldosterone being produced. And because you're not having this aldosterone being produced, you're not taking up the sodium. So you're ending up weeing out the sodium, giving you a hyponatremic picture. You're not ending up pushing potassium or hydrogen ions out. So you're getting a hyperkalemic picture and also a metabolic acidosis picture as well. In terms of glycemia, obviously when you have corticosteroids being produced, that increases glucose as well because it increases the stress response of the body. So if you're not producing those corticosteroids, then you're going to have a hypoglycemic picture. I hope that makes sense. Diagnostic test, so a short synaptin test. Essentially in endocrinology, what will get you out of trouble with these sort of tests, there's loads of them, is that if something is low, what you want to do is try and stimulate it. And then and vice versa, if something is high, what you want to try and do is suppress it. So in Addison's disease, you've got low corticosteroids. So what you want to do is try and stimulate it and see if you can increase it. So a diagnostic test for this would be the short synaptin test. So essentially, you give someone ACTH, and a patient with primary adrenal insufficiency will show no increase in cortisol after the ACTH is given, because the problem isn't the ACTH, it's actually the adrenal glands in Addison's disease. Next slide. Lovely. So the management. So it's relatively simple management. Replace what's lost. So you've got mineralocorticoids and glucocorticoids produced by the adrenal glands. So you want to replace that with fludrocortisone and hydrocortisone. Note here that during an illness, so like sick day rules, the hydrocortisone should be doubled. So the dose whilst you're ill of steroids should be doubled. And that's because when you're ill, your body's going through a physiological stress response. And because of that, you need more steroids to keep yourself functioning. And when you and I are ill, and if we don't have Addison's disease, our body will produce more steroids to combat this physiological stress. And so these people with Addison's disease or any adrenal insufficiency need a double dose of steroids to keep functioning physiologically. Okay, next slide. Okay, so we've talked enough about Addison's disease. We'll go to the other end of the spectrum and look at Cushing's. So the definition is written just there. It can be split up into Cushing's syndrome and Cushing's disease. So Cushing's syndrome is caused mainly by by exogenous steroids. As you know, through other specialities like rheumatology, gastro, obviously highlighted Crohn's earlier. Steroids are widely used in such a wide array of diseases that stuff like Cushing's and Addisonian crisis is such an important concept to nail because they are widely important across a wide array of specialities. Cushing's disease is something that is more tailored towards the pituitary gland and misfunction of the pituitary gland. So essentially, it's an increased ACTH due to pituitary adenoma. So the pituitary adenoma is pumping out all this ACTH, which is affecting the adrenal glands to produce more glucocorticoids, and mineralocorticoids. Okay, next slide. So yeah, symptoms and signs, again, these are the ones you want to look out for with regards to Cushing's. If you look at the picture on the right, that's like a classic Cushingoid patient. So have a picture of this chap here when you're thinking, okay, what kind of things am I trying to figure out from a stem as to why someone might have Cushing's. Alternatively, in your OSCE, you could get given pictures of people with stuff like abdominal striae or a triad of buffalo hump, central adiposity, moon face. Obviously, these are politically incorrect words, but just for the purposes of your education, it's a nice way to try and remember what's happening there. And yeah, it's good to recognize, and these are the things that you should be spotting in your stem to guide you towards a Cushingoid picture. Okay, next slide. So here's a quick slide about striae variation. So if we see on the left-hand side, here's somebody with paler white skin. So you can really see prominent purple striae there. And on the right-hand side, somebody who's more tanned or a darker skin tone. And I just put this slide in here because often there's not enough representation of what things like, particularly like purple striae, look on darker skin. So here it is. This is what it looks like on darker skin, just for your benefit, and look out for that in the hospital. Okay, next slide. Excellent. So let's talk about Cushing's causes. So it can be ACTH dependent, ACTH independent, or you can get a pseudo Cushing's. So if we talk about ACTH dependent, so this is due to an increase in the hormone ACTH, which stimulates the adrenal glands to produce corticosteroids. So as mentioned before, Cushing's disease, so that's an ACTH secreting adenoma. You can also get ectopic ACTH production. So this can be from lung cancer, carcinoid tumors, basically any weird and wonderful malignancy can produce ACTH if it's paraneoplastic, and this can cause a Cushingoid picture. Then you've got ACTH independent causes. So this results in a decreased ACTH. Now that's because these causes produce the glucocorticoids and mineralocorticoids without needing ACTH. So they just override ACTH. So the body picks up that you're producing a lot of these steroid hormones. And then because of that, the body thinks, okay, I need to decrease the ACTH here. So you'll often get in the blood test a decreased ACTH, but a really high steroid hormone level. So that can be due to steroids. Obviously, you don't need ACTH hormone to increase steroids when you're actually just physically taking the steroids. An adrenal adenoma or cancer, again, if it's something affecting the adrenal glands, again with adrenal nodular hyperplasia, if it's something affecting the adrenal glands, it completely bypasses the pituitary gland, and therefore the negative feedback will cause a decreased ACTH, but you'll still have the higher steroid hormones because ACTH isn't needed to produce those steroid hormones. And then you've got pseudo Cushing's, so that can be due to alcohol excess or mental health problems like depression. Okay, next slide. Okay, so looking at Cushing's investigations, now this used to confuse the hell out of me. I've tried to lay it all down in a really simple way, so sorry if I'm like teaching you to suck eggs, but this is how I learned it. So presentation, so you've got your Cushingoid symptoms, which you've gone through. Now, you want to confirm the diagnosis. You want to know basically, is there increased cortisol? So first line would be an overnight dexamethasone suppression test. Don't worry, I'm going to talk through all these tests. So first line would be an overnight dexamethasone suppression test. And your second line would be a 24-hour urinary free cortisol, which is an alternative to the first line. But as you can see, a 24-hour urinary free cortisol is a bit more of a pain to do than an overnight dexamethasone suppression test. And then after you've got that, and you know that there's increased steroids, you want to localize the source. So where is this increase coming from? So there's 3 tests here: a 48-hour high-dose dexamethasone suppression test, CRH stimulation test, and a petrosal sinus sampling of ACTH. And we're just going to talk through each of these tests. So if you can go on to the next slide, please, Isaac. Thank you. Okay, so overnight dexamethasone suppression test. So what happens here is you give someone dexamethasone, and in somebody who doesn't have any adrenal abnormalities, cortisol is suppressed, because if you take that dexamethasone, your body realizes, okay, I'm taking these external steroids. The body doesn't need to produce this cortisol now because we've got this external source of steroids. In a Cushing's picture, there is no suppression of the Cushing's. And now in 24-hour urinary free cortisol, it does what it says on the tin. So you detect a high cortisol in Cushing's. Then in a 48-hour high-dose dexamethasone suppression test, you're essentially looking at whether it's Cushing's disease versus Cushing syndrome. So in Cushing syndrome, there's a failure to suppress the cortisol because it's working autonomously, and no amount of high-dose dexamethasone can suppress a Cushing syndrome producing its cortisol. Whereas in Cushing's disease, there is a successful suppression of cortisol after you give that high-dose dexamethasone. CRH stimulation, again, looks at Cushing's disease versus syndrome. Now, CRH stimulates the pituitary gland, and that produces the ACTH. So when you give CRH stimulation, if there's a pituitary source, so a Cushing's disease picture, then there's an increase in cortisol. Whereas if you give CRH and there's an ectopic/adrenal source of Cushing's, there is no change in the cortisol, because in Cushing syndrome, the steroids are being produced autonomously. Like, it doesn't need ACTH to basically tell it to start producing cortisol. It just does it by itself. And then petrosal sinus sampling of ACTH, you can see that there's a higher concentration of ACTH in the petrosal sinuses, which would indicate towards a Cushing's disease picture. Okay, next slide. Okay, so management of Cushing's. So I've gone through the causes and management specifically to those causes. So iatrogenic cause, stop the medication, but make sure you do it slowly, because you don't want to give an Addisonian crisis, which happens basically if you're on steroids for a long time, your body stops producing their own steroids, and so the adrenal glands atrophy. Now, if you then stop the steroids straight away, your bodies can't produce their own steroid because their adrenal glands have atrophied, because they haven't had the need to produce steroids for a long time because of the medication. In this point in time, you get an Addisonian crisis, and what you need to do is basically give them IV hydrocortisone and get their steroids up as soon as possible. This is a classic thing seen in somebody who takes long-term steroids and probably goes and becomes ill and doesn't increase their steroid intake, or they go through surgery or prolonged surgery and there's not enough IV hydrocortisone given, or none was given, etc., etc. So look out for that sort of question. With regards to adrenal adenoma/carcinoma, you do an adrenalectomy, so just take the adrenal glands out. Ectopic ACTH source, so you need to find that source. So whether that be a cancer in the lungs, bone, etc., breast tissue, excision of that tumor is needed as long as it's not metastasized. With regards to Cushing's disease, there's first, second, and third line. So the first line is what you want to do is do a transsphenoidal removal of the pituitary tumor. Now, if that isn't successful, then you go on to do a repeated attempt and also pituitary radiotherapy. And then your third line would be, okay, we can't take it out from the pituitary, something's gone wrong there. We need to take it out from, the middleman, which is the adrenal glands. And that would cause, you take a bilateral adrenalectomy. And so you stop the thing producing the steroids. Obviously, this is a worst case scenario. And, before we had all this other fancy technology, that would be the first line treatment, a bilateral adrenalectomy, which is obviously not ideal because they'd be on steroids for life afterwards. So this is very rarely seen now, and thankfully so. Next slide. Great. Okay, so let's have a little go at this SPA. Okay, lovely. So B was chosen. So let's just have a little look. Can we go into the next slide, please? Okay, so the answer was actually C on this one. I'll explain why. So, unfortunately, I can't see a little bit of the slide, but I'll bear with me. So, endocrinology clinic, not been sleeping well, increased central adiposity, lost some weight on his arms and legs, reports bruising, stretch marks. So, we're thinking Cushingoid at this point. Past medical history of polymyalgia rheumatica, osteoarthritis, polymyalgia rheumatica, looking at steroid treatment, red herring. He smokes 15 a day for the last 30 years. So he's got an extensive lung cancer history, well, a smoking history, drinks approximately 13 units a week. So if we look at the test results here, so serum cortisol is normal. Its ACTH is raised, okay? So if we look at the low dose dexamethasone, it's at 126. And then if we look at the result after the high dose dexamethasone, it's 153. So we can see that it's not being suppressed by the high dose dexamethasone. So because of that, you're not really looking at a pituitary adenoma picture. Cushing syndrome, the cortisol is normal at this point in time. And again, it will be suppressed by the administration of dexamethasone. The correct answer is lung cancer because there's likely to be a paraneoplastic syndrome as a result of the ACTH being produced by small cell lung cancer. We know that ACTH is really high, and we know that there's been no suppression due to dexamethasone. So it would put you more towards a lung cancer paraneoplastic syndrome picture. It's a hard question, but if you review it after the lecture, hopefully it will make a bit more sense. Can we get the next slide? Great. New question. And yeah, that's the last of the adrenal stuff. So we can move on from that now. Yes, don't worry. Sorry, you will be given normal values for your UCL exam. Do not worry about that. Okay, so can we have the next slide, please? Right, so 54-year-old man, no history, lives well within himself, has a HbA1c of 51. And most of you won't caught out with this little trick. It is the right answer is C. So asked to do another blood test. As you know, this guy's asymptomatic, so you need to do another test. HbA1c is 51, so that is above 48, which obviously is the threshold for thinking about diabetes diagnosis. But because he is well and has no symptoms, we want to do another test in the near future to see if it's just a one-off or if it's like a change which is prolonged and is progressive. So it's really important at this point to obviously emphasize lifestyle measures such as diet, exercise, etc., and his HbA1c is clearly increased. So can we go on to the next slide, please? Yeah, and the next one. So yeah, we're talking about diabetes now. Arguably the biggest topic that I think you'll cover in medical school. So it's very important, and this is like the first time you're properly learning it. So it's good to get into good habits and trying to nail it from now, because I say something for sure, it'll come up in fifth year a lot, and it will come up in final year again a lot. Okay, so type 1 diabetes, insulin dependent. So insulin deficiency due to an autoimmune picture. Again, as I said before, associated with other autoimmune diseases too. So look out for that in a STEM. Type 2 diabetes, so insulin resistance associated with obesity, lack of exercise, and all of that sort of metabolic picture. And then pre-diabetes, so basically you're on your way to diabetes unless you do something soon. So it can be in the form of impaired glucose tolerance or impaired fasting glucose. So yeah, as I said before, they won't get a normal result, but it won't be high enough to call diabetes at that point, and we'll go through that in just a tick. Can I have next slide, please? Great. A quick word on maturity onset diabetes of the young. It comes up in PassMed a lot, or QuesMed, and everyone freaks out about it, being like, "Oh my God, what is MODY?" Blah blah. Typically less than 25 years old. There will be a family. There's normally a family history of this condition, said in the STEM. And then the classic thing that you just need to remember is MODY3, most susceptible to sulfonylurea. And yeah, there's a bit in that table as well, but honestly, don't worry about it too much. Next slide. Great. So diabetes, you have symptoms of hypoglycemia here and the complications. So symptoms, weeing a lot, unexplained weight loss. You can get genital thrush because the glucose coming out in the urine is a great environment for candida. And then you can get lethargy as well, because obviously you're weeing away a lot of glucose. Complications. So I think at this stage and what year you're in, it's really good to be aware of the complications, especially if you get an OSCE station where you're doing some counselling. For example, in our finals OSCE stations that have come up previously, we had like a diabetic foot examination that we did that was asked for the final years to do. Essentially, that was a little bit on the foot examination, but mostly on the counselling on the medication that the person's on, and asking them about that. When me and Isaac did our fourth year OSCEs a couple of years ago, we had a clinical skills procedure, which was a urine dip. And then they asked us questions about diabetes and how that relates to CKD. So it's good to have that sort of knowledge, especially with like the renal component of it, which I think Ollie will go through in a lecture coming up. So yeah, it's good to have a rough knowing of the complications. Vascular disease obviously comes up in your vascular week. Nephropathy ties in with CKD. Diabetic retinopathy is more for next year when you're in fifth year. Cataracts, fifth year. Neuropathy ties in with neuro. Diabetic foot, again, that kind of ties in with vascular, and then a minor one, lipohypertrophy at injection site. So the way you counteract that is trying to just change slightly the different areas that you inject your insulin. So note, as I've put there, an awareness of the complications, what's really needed for your exams. So next slide, please. Thank you. So to diagnose diabetes, you need one set of diabetic results and symptoms of hyperglycemia. So you're thinking lethargy, fatigue, weeing a lot, so polyuria, polydipsia, or you want two sets of diabetic results with someone who's asymptomatic. Now, if we look here, I've made a little table of all the values that you need to know. As you can see, general trend is that pre-diabetes is a little bit less than diabetes. But yeah, this is just for you to have a little look at. And this is something, and I hate rote learning in medicine. I think that it is pointless in the majority of aspects, and that you can learn from first principles. But with regards to these figures, you just got to learn them, unfortunately. Like, it is such a pain to learn them. But as I said before, diabetes is so important. This kind of stuff will, if you ingrain these values into your head, they will help you out literally for the rest of your time as a doctor. Okay, next slide. Great. So management. So pre-diabetes, you want to educate them and do all the conservative management stuff. So talk to them about diet. You know, classic Ionoski's, give them a leaflet about diet and exercise, etc. Type 1 diabetes, insulin. So you want to replace the insulin. Type 2 diabetes is a bit of a crescendo. So you want to go through education first, see if they can lower their blood glucose like that. If they can't, then you go on to diabetic medication. And if it's still uncontrolled, then you go on to insulin. Other stuff you can do as well. So I've taken this bit out of PassMed because it's quite a good flow diagram. Essentially, it's talking about using statins. So primary prevention, you'd want 20 milligrams of statin, and then in secondary prevention, so if someone's got known ischemic heart disease or peripheral arterial disease or any like cerebrovascular disease, for example, like strokes, etc., you want to give a statin of 80 megs once a day. Note their blood pressure needs to be kept at 130/80, so treated with ACE inhibitors. And now new guideline has come in to say that people of Afro-Caribbean origin would benefit more from an ARB instead of an ACE inhibitor. So just try and commit that one to memory. It's just a little niche knowledge, a little bit. Okay, next slide, please. Thank you. And again, this is from PassMed as well. Quite an easy to follow flow diagram on the diabetic drugs. So you've got metformin there as your classic first line drug. And then 48 is the threshold for diagnosing diabetes. Then you go on to give metformin. And then if it's more than 58, then you give another drug with it. And then if it keeps on being more than 58, you add another drug. Basically 58 is the magic number. And if that doesn't work, you can add another drug, or you can go straight onto insulin. But yeah, this is something that just know the overarching rules, which is over 48, you start metformin. If it's over 58, you continue to add on drugs, basically, is what I would personally take from this flow diagram. Okay, next slide. Great. So this is a little slide that I produced, which shows like the management tidbits. So I'm not going to go through all of this now because you don't need me talking through it when it's just there on the slide and you've got the slides. But these are essentially the anti-diabetic drugs that will come up. And on the right are the little tidbits of knowledge that I think are really important for each drug. For you to basically try and put to memory. Again, it's an annoying one where you kind of rote learn it. I mean, you can go on and look at the mechanism of action, but you've got so much to learn in fourth year. Hopefully this slide will basically put you at ease when it comes to anti-diabetic drugs and what you're most likely to be tested on or look out for in a UCL question. Okay, next slide. Okay, so here's a quick roundup of the complications of diabetes. So it's just something to be aware of. So you've got microvascular and macrovascular. So microvascular stuff, retinopathy, nephropathy, and neuropathy. And then your macrovascular stuff is, cerebrovascular, so strokes, cardiovascular, MIs, etc., and peripheral arterial disease, as you would have known from Vascular Week as well. Okay, next slide. Great, so new question. Okay, can we go on to the next slide? So yeah, most of you got it here. So 63-year-old man in the podiatry clinic getting his feet checked, uncontrolled type 2 diabetes, so instantly worried. HbA1c of 61, which is huge. You're really worried. He's missing his medication. He's basically not someone who's complying to his medication. And so you can see a diabetic foot ulcer in that image there. Pseudomonas is the most common bug here in that list, but if Staph aureus was on there, that would be the most common overall in diabetic foot ulcers. Okay, next slide. New SBA. Okay, can we have the next slide? So yeah, you guys are completely right. So thyroidectomy is the right answer. So if we go through this, 24-year-old lady, she's got a fine tremor, weight loss, palpitations, and diarrhea. So at that point, I'm kind of thinking, okay, this is sort of a hyperthyroid picture. She's lived in Cheshire all her life, so she's known to be from developed country in England. On examination, a lump is seen, TFTs are ordered, which show a low TSH, a high T3, and a high T4. And she's got anti-TSH receptor antibodies. So you're given the likely diagnosis, which is Graves. What is the most definitive management? So most definitive means, your invasive stuff, get surgery involved, basically, let's, knock it from the source. And that would be a thyroidectomy in this case. Okay, great. Can we go on to the next slide? Okay, so hyperthyroidism. Here's the axis. So again, a quick run through. This is a bit secondary, but yeah. So you've got TRH, so thyroid releasing hormone, goes to pituitary. That goes into thyroid stimulating hormone, and then that goes to thyroid, and then that produces T4 and T3, which goes into the bloodstream. Again, you have the negative feedback mechanisms, which we'll talk about. Next slide. Okay, so we're having a look at this. So definition, clinical effects of excess thyroid hormone, usually from gland hyperfunction. So the causes are all written there. The most important ones to really note are Graves' disease. Well, that's essentially the most important one, which is circulating IgG autoantibodies, which cause you to stimulate thyroid hormone production. Another one at the bottom is de Quervain's disease, which essentially is caused by some sort of viral illness. So in the stem, you'll get somebody who's had a fever, and then they suddenly have become hyperthyroid. And what you need to do is essentially do conservative management, give them NSAIDs. The rest are there as well for you to have a little gander at later. What I would say is that in our 4th year OSCE 2 years ago, we were given a station where we had to explain a thyroid like radio isotopic, I don't know if I've said that right, scan, which you know that you get those images, which is basically, which shows you like a fuzzy outline of the thyroid gland, and then it's kind of like grayish, and then you've got like really dark black areas of fuzziness, which is where all the thyroid hormone is being produced. We're basically given one of those and then told to explain it to a nurse, and then and then she asked us questions about thyroid hormone and production and what drugs to give, etc. But that was actually quite a nice station because you got to do classic things in an explaining station. So always remember to ask what their understanding is, ask what they want to get out of it first, chunk and check, summarize. So these are the kind of things that even if you don't know what the hell is going on, if you do follow this sort of order and show that you're caring, and show that, you know, even if you have a lack of knowledge, you'll get them a leaflet or you'll ask your senior, you know, that is okay, as long as you don't start like lying or like, you know, trying to fake it till you make it, basically, because the examiner will spot that. And, you know, they're not, you know, expecting you to be thyroid experts. So if you don't know what's going on, just fess up and be like, okay, I'll get you a leaflet. I'm not too sure, but I'll get you a leaflet, or I'll ask my senior and get right back to you, because you will get certain questions. And I certainly did when I was doing this thyroid station, because I was like, I don't know what the hell's going on with this like weird scan. But I did well in that station purely because I was following that sort of algorithm of saying, oh, what do you understand? You know, what are your main concerns about thyroid disorders, and what do you want to learn, etc., summarizing, chunk and checking, etc. So don't worry if you get a question where you don't really know what's going on. It's fine. It's probably just worth a mark or two. Just move on, basically. Next slide. So yeah, symptoms and signs are written here. Again, have a look at this in your own time. These are the kind of buzzwords that you want to be looking for in a STEM where which give away a kind of hyperthyroid picture. Next slide. So investigations. So TFTs, decreased TSH, increased T3, and increased T4. A little note about thyroid antibodies. So TSH receptor stimulating antibodies would give you most likely give you a Graves picture. Anti-TPO would give you a Graves or a Hashimoto's picture. So if we can go on to the next slide. So management. So you've got conservative, medical, and surgical management, which is how in the OSCEs as well. It's a great way to kind of order your thoughts and make sure that you're not all over the place. So conservatively, you can ask them to stop smoking if they've got like thyroid eye disease, etc. Medication-wise, for hyperthyroidism, you've got carbimazole, which you can give to limit the production of thyroxine hormone. Note for that agranulocytosis. So if you get a question where somebody's on carbimazole and they've suddenly got a sore throat, you have to ship them to A&E straight away. Like, they need to go. That person's got to go. Because you're really worried about agranulocytosis at this point. So you want to do an FBC and see what their white cell count is. Because if it's low, they need IV antibiotics in a hospital. Hydrocortisone can also be given in a thyrotoxic storm. Propranolol treats the tachycardia and can also treat the tremor. And then iodine right at the end can be given, and this is like your most invasive medical treatment for hyperthyroidism. Surgery-wise, thyroidectomy, again, as highlighted in the first SBA on thyroid disorders, just get it out, basically. If it's too much, just get it out. Risk of damage, not dame, risk of dame. Risk of damage to the recurrent laryngeal nerve, you might have to give them levothyroxine afterwards. Next slide, please. Okay, your next SBA is here. Great. So can we go on to the next slide, please? Thank you. So 41-year-old lady comes in the GP practice. She's having some episode of diarrhea. Most of you got this right. Repeat TFTs in 3 to 6 months. So she's got a diagnosis of subclinical hyperthyroidism. TSH is low, but a T3 and T4 are normal or higher end of normal. So she's got a subclinical diagnosis of hypothyroidism. So you want to repeat TFTs. She's not in that much distress at all because she's just had some episodes of diarrhea. So you wouldn't need to prescribe a carbimazole. So basically what you want to do the TFTs in a bit of time, see how she's going, basically. Next slide, please. Okay, next SBA. Okay, so if we can go on to the next slide, please. Lovely. Majority getting this right again. You guys are absolutely smashing it. So 44-year-old woman has weight gain and constipation. So she's got symptoms of hypothyroidism. Blood tests. So TSH is 9.1. So it is high. T3 is normal. And also the T4 is normal. So a little bit of a weird picture. This is essentially, because the TSH is high, it is subclinical hypothyroidism. And because she's got symptoms and she's less than 65 years old, she's quite young, you want to trial that levothyroxine straight away. And we'll talk about that in a few slides. Okay, can we have the next slide, please? Okay, next one. Yes, so definition, lack of thyroid hormone. So you've got primary and secondary. So secondary is very rare, basically not enough TSH being produced. due to hypopituitarism. Really rare, not likely to be tested on at all because it is so rare. So with reference to what I was saying earlier with developing countries, etc., the worldwide cause of hypothyroidism is caused by decreased iodine. With regards to us in the UK, Hashimoto's thyroiditis is the most common cause in the UK. So this is an autoimmune disorder. Again, links in nicely with Addison's, stuff like type 1 diabetes, pernicious anemia, etc. And there are the other types there as well. Can you go to the next slide, please, Isaac? Great. So here are the symptoms and signs. Again, I'm not going to go through it because they're just listed here for you as little buzzwords to remember or be aware of when going through a UCL STEM. Okay, can we go on to the next slide? Great. So investigations, primary hypothyroidism. So what you'll get there is, so primary means the actual thyroid gland is mucking up basically, and you get an increased TSH and a decreased T4. Increased TSH because your body's picking up that it's not producing enough thyroid hormone, so it's trying to compensate by giving an increased TSH. Little does it know that the actual thyroid gland is messed up, so it's not going to do anything. Secondary hypothyroidism, again, very rare, decreased TSH due to some sort of hypopituitarism sort of picture. And because there's not that much TSH, there's a decreased, I should say a decreased T4, not a double decreased TSH, but decreased TSH and a decreased T4. Next slide. Okay, so a quick word on TSH level with regards to hypothyroidism. So this caused a little bit of confusion for me. So if we talk through TSH between 4 to 10 and a normal free thyroxine level. So at this point, if somebody is asymptomatic, then you observe and repeat TFTs in 6 months. If somebody is less than 65, so young, with symptoms, then give a trial of levothyroxine and see how they go. And then in older people, follow a watch and wait sort of strategy. So that's the case in both situations where the TSH is even higher. So if they're old, watch and wait. With regards to TSH over 10 and a free thyroxine level of a normal range, you start treatment if they're less than 70 years old. So the way I like to think of it is, if your TSH is if you're really old, then do watch and wait strategy because you don't want to kind of mess up with their system. But if your TSH is more than 10, just treat if they're young. If it's between 4 and 10, if they've got symptoms and they're young, then treat. If they don't have symptoms, then leave them be for a bit. Okay, next slide. Sorry about the ambulance. Okay, next SPA. Excellent. Most of you got this one. Okay, can we have next slide? So yeah, 52-year-old female, fatigue, weight gain, constipation. She's lived all her life in Cornwall, so she's from the UK. GP orders blood tests, specifically TFTs. So here we can see a high TSH, low T3, and a low T4. So we know she's got hypothyroidism. Given the most likely diagnosis, what other test result is most likely to be seen? Now, because she's from the UK, she's got hypothyroidism. most likely she's got Hashimoto's thyroiditis. And as we saw before, an anti-TPO is your classic marker for Hashimoto's. So next slide, please. Right, new SBA. Oh, okay. We've got a split between B and C. How interesting. 50-50 split. Can we go on to the next slide, please? Okay, so people who got B were right. Okay, so 67-year-old man got dialysis. PTH level is high, calcium levels are low, and his phosphate levels are high. With this in mind, what condition does patient suffer from? So, dialysis is a classic, any sort of renal problem is a classic indication for something that is a secondary or a tertiary hyperparathyroid picture. So, all of you are on the right lines with this one. Now, if we look at the results, PTH level is high. You can get that in secondary and tertiary, but the calcium levels are low. And now that would point towards a secondary hyperparathyroid picture. And we'll go through that in the later slides. So can we have the next slide, please? Okay, next one. Okay, so here's the calcium axis. You can go through that in your own leisure. I don't think you particularly need to know it all in depth, but it's good to have just there as kind of a reference point if you ever get stuck. Okay, next slide. Okay, so we're just going to go through hyperparathyroidism. So you can split it into primary, secondary, and tertiary. So primary is due to increased PTH levels, often presenting in elderly ladies with thirst. So you'll get an SBA, which would be like, okay, Doris has come in and she's 80 years old and she's got an unquenchable thirst. And then you do blood tests and you see that she's got high PTH. Normally, it's because of a solitary adenoma, so solitary little bit of the parathyroid glands, which is just pumping out PTH like nobody's business. 20% hyperplasia and 0.5% parathyroid cancer. So it's quite rare to get parathyroid cancer. Secondary, so increased PTH with a decreased or normal calcium level. So essentially what is happening in this situation is that it's normally coupled with somebody who has chronic renal failure. So what happens is you get hyperplasia of the glands due to chronic hypocalcemia or hyperphosphatemia, which are the electrolyte imbalances caused by somebody who's going through renal failure. And a normal physiological response is to increase the PTH, to increase the calcium and lower the phosphate. But because it is a renal problem and a chronic renal problem, because the PTH is continually being stimulated, you end up getting a high PTH, which isn't compensating for the calcium. So that still stays decreased or normal, which was basically the clincher in that first question. Now, had the calcium been high and maybe the PTH be very, very increased, that would point towards tertiary. So that would be essentially where the gland takes autonomous control and starts basically pumping out PTH. It's going into overdrive. It doesn't care what the calcium is. It's just going off its own free will. And it's basically had enough. And it's like, right, I'm fed up of having low calcium all the time. I'm just going to pump out, pump out, pump out. And normally the calcium does rise, but it's not at the same, it's not proportional to how big the PTH rises. Okay, can we have next slide? Okay, so hyperparathyroidism. So presentation is something with which shows increased calcium, basically, and here they are. So you've got you can get depressed, weak, tired, thirsty, dehydrated. You can get conditions such as renal stones, which you'll learn about when you do urology in fifth year. Pancreatitis as well. The classic bone stones, abdominal groans, psychiatric overtones. I think what would be important is this kind of, it's a bit irrelevant, but going into a sort of malignancy picture with hypercalcemia, it's always important to try and ascertain these features from a history. So, ask if you think that there's a history, which I think in fourth year, to be honest, you'll definitely get a 2 week wait history, where somebody's probably coming with a lower GI bleed, or they're having a chronic cough which shows signs of lung cancer that you need a 2 week wait. I think it's really important to ask about these sort of symptoms. So any back pain, for example, for metastases, any pain when you're going for a wee, any constipation that you're having, any changes in mood, which can all be caused by hypercalcemia. And the two most common causes for hypercalcemia is primary hyperparathyroidism, so like a PTH adenoma, a solitary adenoma in the parathyroid gland, or it is malignancy. So that's why this is really important. Okay, and next slide, please. Okay, so the management. So for primary, you want to basically pump them with fluids. They've got high calcium. You want to give them fluids to try and correct that calcium, and also help them wee it out, basically. Cinecalcet can be given as well, which increases the sensitivity of the parathyroid cells. This then helps decrease the production of PTH. Or you can excise the adenoma or the hyperplastic gland. With regards to secondary, so correct the cause. So try and monitor their renal function. Try and correct or increase the EGFR or maintain the EGFR at what it is in their chronic kidney disease. Cinecalcet again, you can give. Vitamin D is really appropriate for their renal disorder, which is something that you'll be able, Ollie will go through more when he does his renal lecture. Phosphate binder again, because they've got hyperphosphatemia. Parathyroidectomy is tricky as well at that point in time, because it is so highly functioning at that point in time. It's quite hyperplased, and it can do a bit of damage if you do that. Tertiary, again, cinecalcet parathyroidectomy. So it's quite simple. Primary, more fluids is your first line, is essentially what you need to get from this, and then the rest is surgery or cinecalcet. Okay, next slide. So quick talk about hypoparathyroidism. Next slide. So you've got the types. So you've got primary, secondary, pseudo, and pseudo-pseudo. So primary is due to decreased PTH due to gland failure. So your parathyroid glands can't produce the hormone anymore. Secondary is due to PTH levels being low due to hypercalcemia and some other factor. So something else, most likely malignancy, causing hypercalcemia, which causes the PTH to be low. So that's a secondary cause of the low PTH. Pseudo hyperparathyroidism is basically your body is making PTH fine, but the receptors that attach onto the PTH are not being able to detect it. Pseudo hypoparathyroidism, I've just put in there just for sake of completeness, but you don't need to know about it for the exam. Next slide. Okay, so symptoms and signs of hypoparathyroidism. So it's the complete opposite to hyper. So you're looking at symptoms secondary to hypocalcemia. So you've got tetany, so muscle twitching, cramping, Perioral paresthesia, a classic thing for hypocalcemia that you'll see in SBAs, is somebody with like a tingly mouth or tingly feelings around their mouth. It's such an odd sensation to have, and it's very specific to hypocalcemia. You've got Trissel's sign as well, and Chvostek's sign, which you can look for as well. What is really important is a prolonged QT interval. Obviously, that ties into your cardiology there. And so what you're really worried about is ventricular arrhythmias, especially torsade de poids, which can happen due to the secondary to the hypocalcemia. Signs of pseudo hypoparathyroidism. I think the only real thing that you need to know, or the clincher, is those short metacarpals. I think they're the ones that I really remember. But to be honest, you're very unlikely to be asked a question about pseudo hypoparathyroidism. Yeah, next slide and final slide. You'll be happy to know. So last one, just going through investigations and management. So primary hypoparathyroidism will give you a decreased PTH and a decreased calcium. So remember, primary hypoparathyroidism is where the gland is failing. So you've got decreased PTH, you're going to have decreased calcium. Secondary hypoparathyroidism is when you've got that increased calcium due to some other process going on, most likely to be a malignancy. And because of that, you're getting a decreased PTH. And pseudo hypoparathyroidism, so a fake hypoparathyroidism, as the name suggests, you still get an increased PTH, but you've got decreased calcium because the PTH can't act, hence why it's pseudo hypoparathyroidism. So management, you can give vitamin D analogs. Calcitriol can be given as well, and then obviously giving calcium supplements because you're going to have that decreased calcium in some of those cases. Not in secondary hypoparathyroidism, but especially in primary and pseudo. Okay, so that's the end of the lecture. We've gone through a few axes there. I think the most important ones for you to kind of nail. Sorry if it was a bit rushed, but yeah, if you've got any qualms, then let me know, and you can email me or Facebook me. It's fine. But yeah, that's it. And thanks for staying on this lovely summer's day. Yeah, and thank you, Isaac, for taking control, because I know that was a bit of a pain for you to do, but I still can only see like 3/4 of the slide. So yeah, thank you for doing that.
No worries, Shwet. What a very lovely lecture you gave. Right, let me stop the recording.